very warm welcome to you all. I am Dr. Nandini Sethuraman. I head the Department of Clinical Microbiology at Apollo Hospitals at Greaves Road. I've been told that you are all in your final year MBBS, so I'm really excited to be connecting with you all. My intention today would be to introduce you to certain concepts in microbiology. Importantly, it is the antibiograms and antibiotic stewardship. Basically, how to use the data provided by your lab to strengthen your choice of antibiotics. Minimal impact on subsequent resistance. So basically, we're dealing with the appropriate drug, use it for the correct dosage and for the correct amount of time, ultimately resulting in the appropriate outcomes that we expect for that particular patient, and minimize the toxicity and appearance of resistance for that organism. So for this particular program to really take off, there are two cornerstones that we say. One is the right diagnosis. You need to make the right diagnosis and treat it appropriately. Right diagnosis and appropriate treatment being the cornerstones for stewardship program. So when a patient walks in with a fever to your clinic or to your hospital, there are fundamentally three questions that you need to answer. First, does he have an infection? And if he does, number two, what is causing that infection? And if you know what is causing the infection, number three, how do you treat it? So this is a landmark study that was done by Kumar and co-workers. The study is titled Duration of Hypotension Before Initiation of Effective Antimicrobial Therapy is the Critical Determinant of Survival in Human Septic Shock. So what they found was that over the first 6 hours after the onset of recurrent or persistent hypotension, each hour's delay in initiation of effective antimicrobial therapy was associated with a mean decrease in survival of 7.6%. So the key word here is effective. So in such stages, you want to know what is the most effective therapy that can be given to this patient without resulting in mortality due to a delay in your choice of antibiotic. So how do we choose the right antibiotic? So there may be two kinds of situations that we're faced with. One is the common syndrome from the community, something like a community-acquired pneumonia, where you know the range of organisms that causes this syndrome. For example, a community-acquired bacterial pneumonia is most commonly caused by a Streptococcus pneumoniae, which is usually susceptible to the third-generation cephalosporins. There also may be other atypical organisms that are causing atypical pneumonia. For these, you can just add a macrolide to the mix and you're safe with this. Similarly, you have syndromic approach treatment for sexually transmitted diseases. However, the situation may not be the same for hospital-acquired infections. So you may get patients who have already been to several hospitals or clinics before coming to you. They may be harboring multi-drug resistant organisms when they come. And in this situation, you need other tools to predict what may be the possible organism that is causing the infection and also what is the possible resistance pattern that it is carrying with it. So there are certain tools that you can use to predict your choice of antibiotic. They are known as the antibiograms. Antibiograms are of two kinds. You can have individual isolate antibiograms. So for example, in this case, you have a patient with a UTI and his urine specimen was submitted for culture and susceptibility testing. The culture showed a significant growth of Escherichia coli and its susceptibilities were ampicillin resistant, cefazolin susceptible, ciprofloxacin susceptible, tobramycin susceptible and cotrimoxazole susceptible. So in this situation, you would choose the drug which has the least collateral damage, something like a cotrimoxazole, which will narrowly only target the Escherichia coli and nothing else. You also have tools like cumulative antibiograms, which basically tell you over a period of time in a particular location, what are the kinds of organisms that exist and what are their resistance profiles. So this data will be provided from the microbiology lab on a periodic basis. So how do cumulative antibiograms help? They help to guide the selection of empiric antibiotic therapy, to identify the emergence of resistance or to monitor resistance trends over time, and to foster prudent antimicrobial prescribing and optimize antimicrobial stewardship. Cumulative hospital antibiograms help to treat hospital-associated infections and also in the surveillance of antimicrobial resistance or antibiotic consumption. In doing so, they help to create antibiotic policies locally for that hospital as well as for states and the country. So this in turn leads to formulation of standard treatment policies and all of this contributes to antimicrobial stewardship. Cumulative antibiograms can even be stratified further, provided there are sufficient number of isolates present. So this stratification can be done based on the kind of infection, that is community-acquired infections versus hospital-acquired infections. They can also be stratified based on the patient location. So that is specific hospital wards. You can have an antibiogram for the ICU, you can have an antibiogram for a ward, you can have an antibiogram for the surgical department versus an antibiogram for the medical department. So this will basically help you to choose the right antibiotic when you're dealing with a patient in any of these specific wards. Similarly, you can also have antibiograms based on the body site. So you can have a bacteremia specific antibiogram. You can have an antibiogram for all your urine specimens. So you will know how to treat UTIs in that particular hospital. And you can have antibiograms for respiratory specimens. So you know how to treat your pneumonias in that particular hospital. So there are certain ways in which you can represent antibiograms. For example, this is an isolation distribution of the top 10 bacterial species isolated from blood in a particular center. So this graph shows that 27.5% of all bacteremias are caused by Escherichia coli and 22.5% of all bacteremias are caused by Klebsiella pneumoniae. Similarly, this situation can change from hospital to hospital and from country to country also. Another way in which you can represent antibiograms is in this particular tabular format. So where you represent the most common organisms that are isolated from your hospital and the drugs to which it is susceptible. So in this example, you have a Staphylococcus aureus distribution of 11.8% susceptible to penicillin, which means that empirically, if you are suspecting a Staphylococcal aureus infection, you can never use penicillin because it will only be susceptible 11.8% of the time. And in this particular center, the oxacillin susceptibility is 78%, which means that the MRSA rate is about 22%. So empirically, you need not suspect that every staphylococcal infection will be an MRSA because 22% only is the MRSA rate. So these kind of antibiograms are released periodically from the microbiology lab. Usually it is quarterly or half yearly, or depending on the size of the lab, it can even be annually. So antibiograms can also be used to detect emergence of resistance trends over time. So we know that bacteria are continuously evolving, and any antibiotic that you introduce newly, the bacteria will find ways to get resistant to them. So in this study, which looked at a decade of change in susceptibility patterns of gram-negative blood culture isolates in one particular center, they found that for all their gram-negatives from year 2003, where there was a susceptibility of almost 80% to cefiperazone sulbactam, it fell down to around 60% in 2013. Similarly, in the ICUs in that same hospital, the cefiperazone sulbactam susceptibility fell to about 50% in 2013 compared to 80% in 2003. So these trends will help us to detect emergence of new drug resistance mechanisms and also help researchers in basic research to look at what could be the possible mechanisms of these resistances. So I've been talking to you about local hospital antibiograms. But we know that bacteria are very smart. They move not only from hospital to hospital, they can move even state borders. They don't adhere to any man-made borders. And therefore, networking is really important when we talk about hospital antibiograms because the practices that you have in your hospital with respect to antibiotics affect not only your hospital but also to other hospitals because patients harboring these organisms are also frequently moving from one hospital to another. And therefore, infection management in any single unit affects infection management across the network. So this kind of network exists in India as well under the aegis of the Indian Council of Medical Research called the Antimicrobial Resistance Surveillance Network. So this is a network of many hospitals, about 25 plus hospitals, both in the private sector as well as in the public sector. We have institutes as well as private hospitals in this network who contribute their antibiotic resistance data to a common server, and this server generates annual reports which are disseminated to all these hospitals and also to other hospitals who are not participating in the network. So this is especially useful for hospitals who don't make their own antibiograms routinely. They can even use these national antibiograms for their use. Similar networks have also existed in the European countries as well as the United States of America for a long time. So the presence of an Indian network also helps us to compare our data with those of the European and US nations. For example, this is the susceptibility of E. coli from all specimens from the Indian network. So if you look at this third generation cephalosporin susceptibility here, the cefotaxime and ceftazidime susceptibility is quite low. That is, it's around 30%. And also that of the carbapenems like imipenem, meropenem, the susceptibility is still quite okay, that is around 70 to 80%. If you look at the European nation data, the third generation cephalosporin susceptibility there is 85 to 86%. Whereas for Indian ICUs especially, it is only 12 to 15%. Carbapenem susceptibility is 99.8% to 100% in the European nations, whereas the Indian ICUs, it is 60 to 70%. Similarly, if you look at the US data, their third generation cephalosporin susceptibility for E. coli is 72% and carbapenem susceptibility is 98%. Taking another example of Klebsiella species, our Indian third generation cephalosporin susceptibility in the ICUs is gone down to as low as 13 to 16%, whereas that of the European nations is 68 to 69% still. And our carbapenem susceptibility to Klebsiella in the Indian ICUs is as low as 36 to 43%, whereas the European nations retain a susceptibility of 93 to 94%. And the US figures are also quite similar to that of the Europe. Third generation cephalosporin susceptibility is 75% and carbapenem susceptibility is 91.6%. In conclusion, antibiograms help us to make the right choice of antibiotics. They can also help to track trends of resistance over a period of time. They can also help in tracking outbreaks of a certain resistance type in a particular unit. Also, they can help to contribute to national and international level databases. And I hope that you will be able to use antibiograms and think of antibiograms when you want to choose an antibiotic for your patient. Thank you.